Inshallah, today we are going to talk about pediatric diabetes. My name is Professor Abdul Mu'in Eid Al-Agha from King Abdulaziz University Hospital, Faculty of Medicine, Jeddah, and this presentation is available in my website aagha.kau.edu.sa. Inshallah, we are going to talk today about introduction of diabetes, types of diabetes, characteristics of each type. We have to differentiate between type 2 and type 2 diabetes because they are the commonest types of diabetes. What are the presentation, diagnostic criteria, causes, comorbidities, and complications, and we end up with management of type 1 diabetes. Before we start, very important to increase awareness of the community about diabetes, as well as to increase awareness of diabetic patients, whether children or adults, about their disease. We give them a lot of information about their disease and their management because unfortunately many patients with diabetes, they are not aware of various causes and various types of management of diabetes, and they are going from one doctor to another doctor without much knowledge of diabetes. That's why, alhamdulillah, I have my own education book for my patients with type 1 diabetes to increase their awareness about the disease. The old definition of diabetes means sweet urine. Diabetes means too much urination. Milliliters means sweet. So the old definition was only a translation. Diabetes, too much urine, milliliters is sweet. But the current definition of diabetes represent a chronic disease of impaired carbohydrate, protein, and fat metabolism. Why? Either insufficient secretion of insulin in type 1 or target tissue insulin resistance in type 2. Insulin is produced by beta cells of islet cells of Langerhans. Islet cells of Langerhans present in the pancreas. In type 1, there is a destruction of these beta cells. That's why type 1 diabetes, the other name is insulin-dependent diabetes mellitus, IDDM. IDDM occurs most commonly in children and adolescents, but can occur in adults. So not only children with diabetes is having type 1, adults can have type 1, provided they are thin. Thin, not obese. Obesity is associated with type 2, but when somebody is thin, type 1 still can happen in adulthood up to late 30s and sometimes early 40s. But the most important thing, as you can see, non-obese adults. Most patients with type 2 diabetes, non-insulin dependent diabetes mellitus, have insulin resistance at the start of the disease. Type 2 diabetes is a progressive disease, starting with normal or high secretion of insulin, end up with many years later on with insulin deficiency. So at the beginning of type 2 diabetes, the patients, whether child or adult, having sort of insulin resistance with acanthosis nigricans. Type 2 diabetes can happen in children, but most importantly, these children or adolescents should be obese. So if you face a child with diabetes and obese, or adolescent with diabetes is obese, think of type 2 diabetes, because type 2 could happen also in children, not necessarily only in adults. There are other inherited forms of diabetes, could happen in children and in adolescents, what is called MODY. MODY is abbreviation of maturity onset diabetes of the young. If we see the types of diabetes in children, children with diabetes mainly type 1 till proof otherwise. It's more than 90% of cases of diabetes in children is type 1, insulin-dependent diabetes mellitus. But still, children could have other types of diabetes. For example, obese children, they could have type 2 diabetes. So it's not 100% type 1 diabetes is happening in children, 90% happening in children, but still 10% could have, 10% of children with diabetes could have other types of diabetes, especially nowadays obesity is a common problem worldwide, including Saudi Arabia. If you go to schools of the children, you find a lot of obesity. And these obese children, they are at risk of type 2. Type 2 is not only for adults. Type 2 could happen in children or adolescents with obesity. There are other inherited forms of diabetes, for example, MODY, as we talk about it, maturity onset diabetes of the young, or neonatal diabetes. When we say neonatal diabetes, means diabetes happens in early age, not only in neonates, up to age of 6 months. So from zero, from birth, up to age of 6 months, if a baby or infant develop diabetes, the name is neonatal diabetes. After 6 months of age, if diabetes happens, it's not neonatal, it's type 1 diabetes. Before 6 months of age, neonatal diabetes. The difference, neonatal diabetes is inherited form of diabetes, while type 1 diabetes is not inherited form, it is autoimmune disease, multifactorial inheritance. Also, diabetes could happen from other diseases. For example, a child with Cushing syndrome might have diabetes, or a child with thyrotoxicosis might have diabetes. So because the reason is not from the beta cells or insulin resistance, the reason from other endocrine or other disease in the body, that's why it's called secondary diabetes rather than primary diabetes. So examples of secondary diabetes include thyrotoxicosis, Cushing syndrome, congenital absence of the pancreas, post-pancreatectomy, secondary to pancreatic damage, for example, children with cystic fibrosis, children with chronic pancreatitis, thalassemia major because of hemosiderosis, those with hemochromatosis, hemolytic uremic syndrome. There are certain rare syndromes could have diabetes. Certain chromosomal disorders could have diabetes, especially children with Down syndrome. They are at risk of diabetes. That's why we have to screen them regularly. Children with Down syndrome, Turner syndrome, Klinefelter syndrome, Prader-Willi syndrome. Diabetes could be secondary to medication, especially steroid, long-term steroid therapy for those, for example, those with SLE, rheumatoid arthritis, inflammatory bowel disease, they are taking steroid, they are at risk of to develop secondary diabetes, and those on chemotherapy, especially on L-aspergillus. Whether diabetes is primary or secondary or inherited, all of them have the same clinical presentation. Polyuria, polydipsia, weight loss, and polyphagia. Polyuria means a lot of urination, frequent urination. Polydipsia means always feel thirsty and always drinking. Despite they are drinking a lot of water, despite they are having polyphagia, too much appetite, they keep losing weight. So if you have somebody losing weight without exercise, without diet, that is called unexplained weight loss, think of diabetes. Think of diabetes. What are the criteria of diagnosis of diabetes? First of all, we should have symptoms of diabetes, as we mentioned before, plus either fasting glucose equal or more than 126 milligram per deciliter. To convert milligram to deciliter, we have to divide on 18. So 126, when we divide it on 18, it becomes 7 millimole. So fasting glucose equal or more than 126 milligram per deciliter, or 2 hours postprandial more than 200 milligram per deciliter, which is equal to 11.1 millimole. Or when we do oral glucose tolerance test, by giving 75 grams of glucose, we test 2 hours after that, still diabetes is defined as more or equal to 200 milligram per deciliter. And the last criteria is hemoglobin A1C equal or more than 6.5%. Let's see what are the normal readings for a normal person without diabetes. Normal person without diabetes should not have fasting glucose more than 100. And those with diabetes, as mentioned, more or equal to 126. And those with between the readings fasting glucose between 100 and 126, that is called pre-diabetes. The same thing for 2 hours postprandial or random. Normal person should not have glucose more than 140 milligram per deciliter. Those with diabetes, they are having 200 and more. And persons having their glucose, random glucose or 2 hours postprandial glucose between 140 and 200 is called pre-diabetes. Lastly, hemoglobin A1C, normal person should not exceed 5.7%. Those with diabetes, their hemoglobin A1C above 6.5, equal or above 6.5, and those with between 5.7 and 6.5 called pre-diabetes. So we have to recognize those with pre-diabetes and those normal and those with diabetes. Why? To recognize because in the stage of pre-diabetes there could be some sort of prevention, especially for type 2 diabetes. We have to emphasize the role of lifestyle changes, diet and exercise. When we come to see the 2 major types of diabetes worldwide, type 1 diabetes and type 2 diabetes. Gender in type 1 diabetes, males equal to females, while in type 2, mainly or more common in females than the males. Why? Because the prevalence of obesity worldwide in females is more than males. That's why females are more susceptible to type 2 diabetes rather than males. Age of presentation, type 1 diabetes is not only for children and adolescents. Type 1 diabetes could happen in those not children or adolescents up to age of late 30 and early 40, provided that they are not obese. Type 2 mainly happens in adult, but also we are seeing a lot of cases nowadays of type 2 diabetes in children because they are obese. So obesity is a hallmark of type 2 diabetes, and not only could happen in adults, also could be seen in type 2 diabetes in obese children and in adolescents. Ethnic group, type 1 diabetes mainly in Caucasian, while type 2 diabetes is having more risk to happen in Indians, African American and Hispanic. Type 1 diabetes is associated with autoimmunity. Type 2 has nothing to do with autoimmunity. Obesity is a hallmark of type 2 diabetes, has nothing to do with type 1 diabetes. And with obesity, there is something called acanthosis nigricans. Acanthosis nigricans is thick and dark skin behind or around the neck, in the axilla and in the groin. That is called acanthosis nigricans. Is a hallmark of insulin resistance, and insulin resistance is associated with type 2 diabetes rather than type 1 diabetes. Family history is very common, is very frequent in type 2 diabetes, while it's not frequent in type 1 diabetes, and that's why a lot of families, when they brought their children to emergency room and we diagnosed them with type 1 diabetes, they were all saying, why diabetes happened in my child? I don't have any history in the family with type 1 diabetes. Why my child got type 1 diabetes, we say this is the common feature of type 1, no family history or infrequent family history of diabetes. Insulin resistance has nothing to do with type 1 diabetes, while it is a major factor for type 2 diabetes. When we see the pathophysiology of diabetes, type 1 and type 2 is a polygenic diabetes. What is the meaning of polygenic? Polygenic means environment and genetic. So, if somebody asks you, is type 1 diabetes is inherited or type 2 is inherited, you tell them it's not a pure inherited disease, it's not a Mendelian inherited disease, it is a polygenic disease. So the person should have genetic susceptibility, but genetic susceptibility alone is not the reason. It should be combined with environmental triggering factor. Environmental triggering factor to happen بعد مشيئة الله عز وجل. While the monogenic disease means only pure inherited disease. For example, Moody. Moody doesn't need to have environmental triggering factor. Moody is 100% genetic disease. So only genes, no environmental factors. The same thing for neonatal diabetes mellitus. Neonatal diabetes mellitus has nothing to do with environment. Pure 100% genetic mutation. If we see type 1 diabetes, the genetic part of the pathophysiology, we have to do something called HLA screening. HLA screening, they found that those with DR3, HLA DR3 and HLA DR4, they have a strong genetic susceptibility to develop type 1 diabetes, estimated about more than 90%. More than 90% risk to develop type 1 diabetes if somebody got HLA, DR3 or DR4, DR3 and DR4. But see, the risk is 90%, is not 100%. Why 90%? Because still there is a 10% environmental triggering factor. That's why type 1 is not pure genetic, it is a polygenic or multifactorial. What are the environment? If we look to the genetic issues of type 1 diabetes, there is something called HLA screening. When we screen type 1 diabetes patients, we found them, most of them, or more than 90% of type 1 diabetes, they have got DR3 and DR4. So DR3, HLA, DR3, HLA, DR4 make a strong association to develop type 1 diabetes. But the estimated percentage is 90% to develop type 1 diabetes. So this genetic susceptibility is 90%. It's not 100%. Why it's not 100%? Because it is not a pure genetic disease. It is a combination of genetic and environmental. So there is a 10% from the environmental triggering factor. What are the environmental triggering factors for type 1 diabetes? They found that viral infection is one of the important environmental triggering factors, and mainly if somebody developed mumps, rubella, Coxsackie-B4, or any viral infection. But viral infection in a normal person without genetic susceptibility will never, بعد مشيئة الله, will never give type 1 diabetes. But viral infection in those with genetic susceptibility to diabetes will develop بعد قدر الله type 1 diabetes. So environmental factors is important only for those who have genetic susceptibility to develop type 1 diabetes. The other triggering factors, we have nutrition factors, especially cow's milk feeding in infancy. So we encourage all the mothers to lactate or to feed their babies in first year of life with their own breast feeding rather than bottle feeding, because bottle feeding or artificial formula feeding is associated with increased risk of developing autoimmune diseases, including type 1 diabetes and allergic diseases. Also, recent evidence suggests the role of vitamin D deficiency in the pathogenesis and prevention of type 1 diabetes. Vitamin D deficiency is very common in Saudi Arabia. That's why a lot of studies indicate that type 1 diabetes in children in Saudi Arabia is increasing year by year, maybe because of vitamin D deficiency. That's why we are encouraging all the audience to screen themselves for vitamin D, and if they are deficient, they should have a replacement therapy for vitamin D deficiency, because vitamin D is important to prevent, inshallah, or to help in prevention of autoimmune diseases, including type 1 diabetes. And also, one of the possible triggering factors to develop type 1 diabetes is toxic chemicals present in the food, for example, food preservatives and coloring agent. As you know, a lot of children loves to have, the sweets with color. So when they eat the sweet with color, sometimes their tongue becomes red, green, blue. They love it. But we don't know that these coloring agents and preservatives in the food might damage their tissues, including inducing autoimmune process destruction of islet cells. So be careful when you give your children food containing preservatives or coloring agent. When we have the genetic susceptibility, in addition to the environmental triggering factor, autoantibodies will develop. Autoantibodies will develop against beta cells. We have so far 5 autoantibodies we could test for children with type 1 diabetes. We have something called zinc transporter 8 antibody, which is a recent autoantibody. We have something called glutamic acid decarboxylase antibody, islet tyrosine phosphatase antibody, insulin autoantibody, islet cell antibody. They have found that more than 90% of newly diagnosed diabetes have positive antibodies to confirm diagnosis. But in real practice, not every child with type 1 diabetes, we do for them antibodies, autoantibodies, only in children with possible other types of diabetes. For example, if you have a child or adolescent obese and present with diabetes, because his child 90% chance to have type 1 diabetes. Because he is or she is obese, there is a risk of type 2 diabetes. So in this certain situation, we have to confirm if this child having type 1 diabetes, or if this child or adolescent have type 2 diabetes. We have to do autoantibodies to differentiate between type 1 and type 2 diabetes. But it's not a routine for everybody with type 1 diabetes to have screening for autoantibodies. Regardless of the type of diabetes, whether this diabetes is type 1, whether this diabetes is type 2, whether this diabetes is moody or secondary diabetes, all present with the same manifestation. As mentioned earlier, polyuria means passing a lot of urine, nocturia, passing urine during sleep, so the patient has to be awake and go to bathroom to pass the urine, which is unusual for a normal person. Sometimes children cannot control themselves and they have some what is called secondary nocturnal enuresis. Secondary nocturnal enuresis as a manifestation of diabetes. Also, diabetes can present with a lot of thirst, increased thirst sensation, with secondary osmotic diuresis leading to dehydration. Also, children and adults with diabetes, usually most of the time, they feeling themselves as weak, generalized malaise, headache, weakness, irritability, and their behavior become bad behavior, what is called bad temper, because when they have high glucose, the brain cannot utilize the high glucose for the energy, so they become irritable, and their behavior changed because of not getting benefit of high glucose. Despite they have high glucose, despite they have high appetite, they keep losing weight. And as I mentioned earlier, unexplained weight loss is one of the manifestations of diabetes. And in children, the mother might notice that her child is not growing up or losing weight because of diabetes. Hyperglycemia could be complicated if not treated immediately or urgently with insulin, could lead to what is called one of the acute complications of hyperglycemia is diabetes ketoacidosis. Diabetes ketoacidosis means the formation of acetone. Why formation of acetone? Because the body could not utilize the glucose for energy production. That's why the body starts to break down the fatty acid to produce acetone, because acetone is the second source of energy. So will be formation of acetone. The patient will have a smell of acetone, and acetone formation or ketone body formation lead to metabolic acidosis. So in ketoacidosis, a triad of hyperglycemia, ketone formation, and metabolic acidosis. That will lead to the patient who might have, in addition to the polyuria, polydipsia, weight loss, polyphagia, might have in addition to that abdominal pain, vomiting, drowsiness, might go into coma, and the type of breathing will be rapid breathing. Why rapid breathing? Because the child wash out CO2 to compensate for metabolic acidosis. That is called cosmal breathing. This is very important to ask the history about symptoms of diabetes and symptoms of ketoacidosis. Also, there are some non-specific symptoms of diabetes. For example, hyperglycemia will impair the phagocytic function of white blood cells, makes the child always susceptible to recurrent infection, particularly urinary tract infection, skin infection, and respiratory tract infection. Also, will never forget candidiasis, oral candidiasis, and in females, vaginal candidiasis. Physical examination. Any child with diabetes should have full physical examination, including growth assessment, injection site examination, fundoscopic examination, examination of the hands, feet, peripheral pulses, examination for signs of limited joint mobility, examination of peripheral neuropathy, tendon reflexes, examination of signs of associated other autoimmune disease, because type 1 diabetes could happen isolated or could happen in association with other autoimmune disease. The commonest 3 associated autoimmune disease with type 1 diabetes, number 1 is celiac disease, number 2 is Addison disease, number 3 autoimmune thyroid disease, whether it's Hashimoto's or Graves' disease. So we have always to think of these three associated autoimmune diseases in any child or adolescent or adult with type 1 diabetes. Repeat again: celiac disease, Addison disease, autoimmune thyroid disease. Also, child with diabetes or adolescent should be having blood pressure regularly checked up, as well as annual urine microalbuminuria. Urine microalbuminuria is the first manifestation of nephropathy. Investigations. Initially, we have to do for the diagnosis fasting glucose, random glucose, and hemoglobin A1C, and then regularly with each clinic visit we have to test for plasma glucose, urine ketone, hemoglobin A1C, which is glycosylated hemoglobin A1C. That is very important initially to diagnose type 1 diabetes or type 2 diabetes. Any type of diabetes should be screened by hemoglobin A1C. As mentioned before, any reading 6.5 and above is considered to be diabetes. But also hemoglobin A1C has another important value in any child or adolescent or adult diabetes to recognize the control of the disease. If we have up to 7% hemoglobin A1C in a patient with diabetes, that is a good control. Any reading up to 7%, that is a good control. Readings between hemoglobin A1C between 7 and 9, this is an average control, and the readings above 9% is a poor control. So any patient worldwide having hemoglobin A1C more than 9%, that is a poor control. And the problem of poor control will increase the risk of diabetes complications. Every year, annual, we have to do renal function test. Annually, we have to do thyroid function test, thyroid antibodies, celiac antibody screening yearly, lipid profile, urine microalbuminuria, liver function test. By the way, hemoglobin A1C should be done every 3 months. Management of diabetes will include, number one, education. We have to concentrate on educating our patients on diabetes. Unfortunately, in our community, when you sit with patients with diabetes, they don't have enough knowledge on diabetes. They don't have enough management issues about how to manage their diet, exercise, various types of insulin. They don't have much information. And their information is mainly from the internet, from the WhatsApp, and believe me, the sites or the websites, when they go to read about their diabetes, not all of them is having a true information, sometimes a misleading information. So from our part as a physician, we have to concentrate on educating our patients with the true informations and true knowledge rather than false knowledge present in some websites. Number two management issue in type 1 diabetes is insulin therapy. Insulin therapy, we have various types of insulin. I'm going to talk about it in the slides after that. We have also to concentrate on children or adults with diabetes on their psychology. We have to support them psychologically. We have to be careful when we deal with a child or adolescent diabetes. They are very sensitive because of their disease. We have to be with them very polite and careful in the way we talk with them. Blood glucose monitoring is very important, and blood glucose monitoring for any patient with diabetes on insulin should have at least minimum four glucose checkup per day, before breakfast, before lunch, before dinner, and before going to the bed. But alhamdulillah, recently we have a continuous glucose monitoring sensors. I'm going to talk about it, which is one of the diabetes technology available in Saudi Arabia. That is, you could see the whole day glucose reading by what is called non-invasive glucose monitoring glucose sensors. Healthy diet is very important. Healthy diet is very important for any patient with diabetes. Exercise, and main exercise is swimming and walking. Walking and swimming is the best exercise for patients with diabetes. When we come to the history of the insulin therapy, because insulin therapy is the main therapy for type 1 diabetes, that's why the disease is called type 1 diabetes, is called insulin dependent diabetes mellitus. So insulin is very important in the management, and the first person who discovered the insulin was Professor Banting Best. Professor Banting Best, he was a professor of orthopedic. Discovered the insulin on 1922. 1922. From the year 1922 till this year, 2020, nothing else to treat type 1 diabetes apart from insulin. So still the insulin is the main therapy. But of course, from 1922 till now, it's almost 100 years ago, almost 1 century ago, discovered the insulin. There are plenty of modification of the insulin to better and better chemical formulation, but still we could not have any other choice to treat patients with type 1 diabetes. This is a Professor Banting, and this is his co-worker, his medical student called Best, and this is the dog and the pancreas of the dog. The first insulin was derivative of dog pancreas, and then the process of insulin industry was improving year by year till we have now, from 1984, year of 1984, we have something called human recombinant DNA technology to make the insulin. So now all the insulin available nowadays and since 1984 is human recombinant DNA technology insulin, pure insulin, very good character of insulin rather than animal derivative insulin in the past. And this is the first child was treated with the animal insulin long time ago. If you can see the slide, this child with type 1 diabetes almost dying. If you can see, almost in comatose, opening the mouth because of rapid breathing, dehydrated, cachectic, almost nothing, no skin and bone. Why skin and bone? Because he could not utilize the glucose for energy production, so the body broke down all the fat tissue to get the energy by formation of ketone, so the child was skin and bone, almost dying. What happened after giving the insulin? 30 days after giving the first insulin, injection of insulin, see what it happens. Different person. This is a true slide. This person, dying person, became a healthy person. Why? بعد فضل الله, because of insulin. Insulin, insulin, and insulin. So insulin dependent diabetes mellitus. This slide I love always to give it in my presentation to show people how the importance of good management of diabetes, converting somebody dying into completely healthy growing up child. The message here, insulin is the mainstay therapy for type 1 diabetes. Insulin therapy, we have various formulation, chemical formulation of insulin, and the doctor has to choose the best insulin according to child age. So the message, not all children should be receiving the same type of insulin, depends on their age, depends on their lifestyle. For example, somebody eating snacks, frequent snacks, a child eating frequent snacks should not have the same insulin formulation of somebody does not eat food snack. Only he's eating or she is eating 3 main meals without snacks. Also, young age group children should not receive the same insulin as older age group children. Socioeconomic factors. If the family is poor or is having low socioeconomic class, we should not give them expensive form of insulin. There are other choices, good choices, we could use them, which is a lower cost than the new expensive insulin. And always we have to discuss with the family about in the insulin, how the insulin works, what is the peak of the insulin, duration of the insulin, what are the characteristics of insulin. Very important to have the family involved in our decision. But the message here, everyone has different needs of insulin than the others. Never compare your child or your relative with another child because the other child is taking less dose than my child, the other child is taking this type of insulin, while my child is taking another type of insulin. Everyone is different from the other. So no comparison between the child and his colleague or his friend. And when we treat type 1 diabetes with insulin, we might have some episodes of hyperglycemia, we might have some episodes of hypoglycemia, but the good management most of the time to make the child most of the time euglycemia, not hyper or hypo, although we never ever could prevent hyperglycemia or hypoglycemia in a child or patient on insulin, but as much as possible to make most of the readings in euglycemia range. If we have to discuss about insulin types, these the various insulin types. We have short-acting insulin. The good example of short-acting insulin is something called Actrapid and Humulin R, regular insulin. We might have rapid-acting insulin analog in the market. We have 3 brands of rapid-acting insulin analog so far. We have Lispro, which is the Humalog. We have Aspart, which is the Novorapid, and we have insulin glucosine, which is Apidra. All these under category of rapid-acting insulin analog. Short-acting insulin and rapid-acting insulin, they are used as a bolus. So when we treating a child or patient with diabetes should have 2 types of insulin. One is called bolus insulin. Bolus insulin means for food, for the meals. And the other type of insulin should be something called basal insulin. Basal insulin has nothing to do with food. It is for maintaining the euglycemia between meals and during sleep. So the other remaining 3 types of insulin are considered to be basal insulin, either intermediate acting insulin MPH or long acting insulin analog. For example, we have Glargine, which is Lantus, Ditimir, which is the Levemir, Digludec, recently Digludec insulin, which the name is Tresiba, insulin Glargine 300 Toujou. All these are various types of insulin. And as I mentioned, the first 2 category, short-acting, rapid-acting, bolus. The remaining 3 categories, intermediate, long-acting insulin, basal analog, they are called basal insulin. The doctor should select one choice from the bolus insulin and one choice from the basal insulin. The patient should have 2 types of insulin, one for food, basal insulin for maintaining the euglycemia. If you see this slide, as I mentioned before, we have rapid-acting insulin, analog, or short-acting insulin. The difference between rapid-acting insulin analog and short-acting insulin, rapid-acting will act fast from the name, rapid. So it works through 5 to 15 minutes to the patients before food, or sometimes after finishing the meal, could have inject himself or herself with rapid insulin. It will work through 5 to 15 minutes. So this is an advantage. Also, if you can see, the peak effect is 1 to 2 hours. And this is good to prevent postprandial hyperglycemia. And the duration is very short duration, about 3 hours. This short duration, 3 hours, in some patients is advantage, in other patients disadvantage. That's why not every patient should have rapid-acting insulin analog. They might have second choice, which is short-acting insulin, which is the regular insulin, Humulin R, Actrapid. The difference is duration. Duration in the short-acting is 6 to 8 hours. Duration of rapid-acting 3 to 4 hours. So those patients doesn't eat snack and only meals, very good for them to have rapid-acting insulin because they don't need a longer duration bolus. They don't eat snacks. While in our community, majority of children and majority of adolescents keep eating snacks between meals. If they keep eating snacks between meals and they are using rapid-acting insulin will not cover snacks. So their sugar or blood glucose is high. So we need to shift them to short-acting insulin, regular insulin, because the duration of coverage is 6 to 8 hours. Or the other choice, we could ask them, those taking rapid-acting insulin, to inject themselves for the main meals and for the snacks. If they agree to have frequent injection, multiple daily injection with every meals and every snack rapid-acting insulin is fine. If they are refusing to take with every snack an injection, they want only with the main meals injection, so short-acting insulin is a good example of a bolus for those having frequent snacking. With a rapid-acting insulin analog or short-acting, we have to select one of them for a bolus. And these, the remaining types of insulin, as you can see in this slide, is basal insulin. The MPH has a peak and duration only 12 hours, so patients on MPH should have it twice per day as a basal insulin because the duration is 12 hours. While the new basal analogs, especially glargine or degludec, they having extended daily cover, and most of the patients currently they are using either glargine or degludec because of 24-hour coverage, and degludec sometimes up to 40 hours coverage. And as you can see, it's a peakless insulin, so we don't need a peak for basal insulin. We need a peak for bolus insulin, but we don't need a peak for a basal insulin, and that's why one of the good choices to use basal analogs for our children with diabetes. There are plenty of insulin coming to the market day by day, and if we see the methods of giving the insulin, we have either conventional method. Conventional method means twice per day injection, one before breakfast and one before dinner, and this was the old method to give insulin. Nowadays, nobody use conventional therapy because it's been associated with a lot of poor control diabetes and with complications. So people start to shift into intensive insulin therapy rather than conventional insulin therapy. From the year 1993, there was a big trial worldwide called DCCT. D means diabetes, C control, another C complication trial, DCCT. This trial was done over 10 years of duration in Europe, in America, in Canada, in a lot of Western countries, and they were dividing the patients between conventional therapy, twice per day therapy, and multiple daily injections, intensive therapy, and they were following up these patients. They found that those intensive therapy, they have a lower hemoglobin A1C as well as lower diabetes complication in comparison with twice per day injection. So from year 1993, most of the endocrinologists, most of the diabetologists shift their patients from twice per day injection into multiple daily injection. And this is what I mentioned, DCCT data. They said those on multiple daily injection, they have a lower hemoglobin A1C. And if you can see, when you have lower hemoglobin A1C, inshallah, you'll have low risk of complication. If you have higher hemoglobin A1C, your risk of complication is increasing. And that's why, as a physician, we are concentrating to keep most of our patients, their hemoglobin A1C in the target range. And this is the BAS, twice per day injection, and we could have 3 times per day injection, but the most recommended method of giving the insulin therapy is what is called basal bolus therapy. Basal bolus therapy, between 2 brackets, minimal 4 daily injection, the bolus with food, and the basal once per day, so total at least 4 per day injection. In year 2014, there was approval of inhaled insulin called inhaled insulin therapy, Afrezza, rapid-acting insulin therapy as inhalation through the lung. So the patient will inhale the insulin, and the capillaries in the alveoli will absorb the powder of the insulin, and that is like a rapid-acting insulin. But the problem, in some patients, they deteriorate their lung function. That's why it's not highly or widely used worldwide. Insulin therapy is very important, very good technology, diabetes technology, to improve the control of children, and it is one of the best modality to deliver insulin worldwide. Insulin pump therapy also has improved from the past with big machines into recently small pager-like machine to deliver the insulin. Insulin pump therapy works continuous delivery of insulin, mimics physiological insulin production, improves glucose control, reduce the incidence of hypoglycemia, normalize lifestyle, no insulin injection, flexible insulin adjustment. All they are very good to improve the compliance of patient with insulin, taking insulin. Another diabetes technology called continuous glucose monitoring system, CGMS. And these sensors, they are inserted under the skin. They are measuring the glucose from the interstitial fluid glucose rather than capillary glucose. So they are measuring the interstitial fluid glucose, and this is the sensor where it is inserted in the subcutaneous tissue and measuring the glucose continuously, and the results will be shown in the screen of the machine. And this is the example of a child wearing subcutaneous glucose sensor. No need to test their fingers, break their fingers for glucose. This sensor measuring the glucose continuously, and the patient is aware of the whole day glucose reading. When glucose sensor works with the insulin pump together, that is called sensor dependent insulin pump therapy. As mentioned earlier, insulin therapy by injection or by giving through insulin pump is the mainstay of treatment of type 1 diabetes. In 1999, Professor Shapiro from Edmonton, Canada, developed a new technology to treat type 1 diabetes by what is called islet cell transplantation. What is that? It's just by using cadaveric islet cell and make it pure and cover it with a substance that prevent autoimmune destruction, and then transplant these islet cells into the liver surface, up on the surface of the liver. What happens in 1999 after the transplantation, islet cell transplantation? A lot of success. A lot of people thought that diabetes is finished. Diabetes now is curable disease with islet cell transplantation. But unfortunately, despite this technology, a very beautiful technology, unfortunately, the transplanted islet cells were distracted by autoimmune system again throughout 1 year, some patients 2 years, 3 years. In addition, when they are over the liver, surface of the liver, some patients develop raised liver enzyme, other patients develop jaundice. That's why it's not popular in the technology tool to treat type 1 diabetes, and still a lot of center improving this technology. So we don't advise our children or family to go for islet cell transplantation, as well as stem cell transplantation, which is a very important development in diabetes to treat or cure diabetes with stem cell transplantation, but still till this time under development. Also, we don't advise people to go to Ukraine or China or India. They are promoting that they have successful stem cell transplantation for children with type 1 diabetes. This is not true. Still, this process is under development, is still not fully developed. When we come to diabetes complications, if you can see between two brackets, not for anyone, only for those with persistent high hemoglobin A1C. So this is the message we should inform our patients, that if somebody is taking care of himself or herself, getting most of the glucose reading in the range, doing diet, healthy diet, doing good exercise, follow up with the doctors, follow up with the educator, with dietitian, inshallah, the risk of complication is very low. And the opposite, if somebody is not taking himself or herself or himself care, eating whatever wants, doesn't take enough injection of insulin, doesn't test the sugar, doesn't do exercise, not in healthy diet, not follow up with the doctors, the hemoglobin A1C will be higher and the risk of complication will be higher. So من جد وجد. Retinopathy is one of the complications of diabetes, cataracts, hypertension, progressive renal disease, early coronary artery disease, peripheral vascular disease, neuropathy, both peripheral neuropathy and autonomic neuropathy, and risk of repeated infections. As I mentioned, all these complications not for anybody with diabetes, only for those with poor control diabetes. Those with good control, inshallah, they will not have these complications. Associated autoimmune diseases with type 1 diabetes, as mentioned earlier, we have celiac disease, we have Addison disease, and we have autoimmune thyroid diseases. By this, I end up my presentation. All the best.